Hi friends, good evening. I'm Dr. Ashutosh Gupta. Today we are going to talk about placentomegaly, right? Placenta is an organ. The main function is to guard the pregnancy first, and then to suck up the nutrition which is available, that is the blood, that is being available from both the uterine arteries, and to supply to the baby, right? So the placentomegaly, whenever it is there, right? So this is the effect. This could not be the cause, right? So the placentomegaly, whenever it is there, it is always omnious, right? How do we define the placentomegaly? Gestational age plus 1 centimeter. So if it is 18 weeks of pregnancy that we are seeing, it should be 1.8 plus 1 centimeter. So anything which is greater than 2.8 centimeters, so at a gestational age of 18 weeks, it becomes abnormal, right? So gestational age plus 1 centimeter, and if it is greater than that, that becomes placentomegaly. Now, placentomegaly can happen because of fetal anemia, because of some infections, because of some sort of an twin to twin transfusion syndromes, or probably we can have a partial sort of a mole, and therefore, but per se, the placentomegaly is the effect, meaning thereby that the placenta is like a goiter. So whenever we are dealing with an iodine deficiency, whenever we am suffering from iodine deficiency, my thyroid gland is going to increase in size so as to compensate, and so as to try to find iodine available into my blood, and therefore we'll try to search for that iodine, and therefore this goiter is the effect of it, right? So whenever the placentomegaly is there, so this becomes a sinister finding. Secondly, what we can get in the background is this, that probably since the uterine arteries are not working very well, and therefore the blood to the baby is mere, and therefore the placentomegaly is there. Just to salvage this whole condition, what would happen is this, that the baby would go into an auto-regulation mechanism, meaning thereby that the baby would try to maintain the vital organs at the expense of the non-essential or the peripheral organs. During this precarious times, what would happen is that the baby would get into an auto-regulation and would try to maintain the blood, or try to maintain the circulation to the vital and the essential organs. So essential organs are only four, which is brain, heart, adrenals, and then liver, right? So which is very very essential to for the sustainability of the baby. So what would happen is this, that on the expense of the central circulation, the peripheral circulation would get cut down. So meaning thereby that musculoskeletal, splanchnic, musculoskeletal meaning thereby muscles may, splanchnic meaning thereby gut may, and to the kidneys. Kidneys are also not that essential. So the blood supply to the kidneys would also get shut down. So how does it manifests is this, that probably we would have an IUGR with an abnormal Dopplers, we'll get an IUGR, we'll get an oligohydramnios, and then we can have a mesenteric ischemia. So mesenteric ischemia is this, that the splanchnic circulation has been cut down, and therefore we are having a grade 2 echogenic bowel. So placentomegaly in the background of the uteroplacental insufficiency with oligohydramnios and grade 2 echogenic bowel or mesenteric ischemia is a very very sinister finding, right? So let us first see this case, and then probably we'll talk about further. So this is a case that we are seeing at 23 weeks. Okay. So now you see that there is a huge placenta, right? So placentomegaly is something like a huge giant wave, tsunami wave, which is trying to press upon the baby. It was something around 7 centimeters, and then it is very huge and homogeneous. Then we looked down to the abdomen. So, as expected, we identified it to be a grade 2 echogenic bowel. So, sign of a mesenteric ischemia. Then we got onto the uterine arteries, and therefore we identified the post-diastolic notching in both the right and then in the left uterine arteries, suggesting that the uteroplacental insufficiency is there. Then we went on to the umbilical artery, and rightfully we identified the reversal of the flow in the umbilical artery, right? So from an high resistance to absent, now we are having a reversal. Now ductus venosus is still having a continuous forward flow of A wave, right? So this we will talk about, and very severe IUGR with oligohydramnion. Ductus venosus is a vessel that supplies the blood directly to the fetal heart. So in a cases of hypoxia, or whenever the blood flow is less and then the oxygen supply to the baby is less, what happens is that this is a funnel shaped structure, this dilates. So meaning thereby that there is a dilatation in response to the hypoxia. and therefore the blood flow with this, as you've seen, with the reversal of the end diastolic flow in the umbilical artery, still the there is a continuous forward flow of the A wave in the ductus venosus. So ductus venosus would be the last and the penultimate vessel to really lend up the end-to-end reversal of A wave by the time the baby would be moribund, right? So the placentomegaly, the placenta was very huge. We identified that the mesenteric ischemia was there, oligohydramnios was there, the Likert was 7, and it was a very severe IUGR. Then we looked around into the uterine arteries. The flow was absolutely mere, and with the post diastolic notching, and then we saw the reversal in the end diastolic flow in the umbilical artery. So, meaning thereby that at 23 weeks, we identified that the baby was something around 19 weeks and we had severe IUGR of something around, and that the baby was weighing the very, very less, and severe IUGR is there. So, all these things they could have been picked up very early. So, placentomegaly is the effect, it is not the cause. The cause is this, that probably the blood supply from both the uterine arteries was abnormal. Somebody should have highlighted all these things at 12 weeks. We could have taken a corrective measures at 12 weeks of giving her equaspirin and low molecular weight heparin. We could have looked around that how the baby is responding and titrating the doses of the low molecular weight heparin at 16 weeks. From starting from the 12 weeks to something around 23 weeks, we could have done something, and therefore this umbilical artery flows from the high, they have gone into absent. Now we are getting into an reversed end diastolic flow in the umbilical artery, and therefore hardly anything is left now at the moment, because in the blood flow to the baby, so baby might get into a right ventricular failure at any time, right? So the whole scenario is this, that probably identifying all these things at the right time can really help us in salvaging the pregnancy, right? So 12 weeks ultrasound with uterine Dopplers is a mandatorily thing should be done, right? More so by a fetal medicine specialist, right? Thank you very much for your patience.